Thank you for joining us today as we discuss the mind, body, and the nerves, and most importantly, the daily life with acute porphyria. My name is Myra Martinez. I'm an advocate with the UPA, and I have acute intermittent porphyria myself. I am honored to be part of what United Porphyrias Association is doing today as a community where we are involved in many things, but I take pride in the five things that we do really, really well, and what is research, education, awareness, advocacy, and support. We're happy to welcome Dr. Mohamed Kazamel, who is a renowned neurologist and a porphyria expert. We are very fortunate to have him be part of our team. And when I say our team, I mean the porphyria expert team. And not only that, but also a member of the UPA Scientific Advisory Board. Dr. Mohamed Kazamel is a neurologist at Mayo Clinic. He specializes in autonomic and neuromuscular disorders. He's widely published on hereditary, inflammatory, and neuromuscular disorders. He really knows everything there is to know, I believe, about toxic neuropathies. Lots of questions will come up about that, I'm sure, today. Dr. Kazamel is heavily involved in multiple clinical trials for peripheral nerve and neuromuscular junction disorders. He has been an expert of the Porphyrias Consortium and now part of the American Porphyria Expert Collaborative since 2019. So, Dr. Kazamel, thank you for being here with us today. Thank you for sharing your knowledge with us. The time is all yours. Take it away.
Well, thanks, Myra, for the introduction. I'm always grateful to the United Porphyria Association and what they do for us and our patients. And the team led by Kristen Whedon is quite an excellent team. And it has been a privilege and honor to work with you guys all over the last years. Today, we are going to talk about a very important subject to our patient, which is pain in acute hepatic porphyrias. And we're trying to talk about initially about pain in general and understand what are the general mechanisms of pain and why would pain continue to be there even after the painful stimulus ceases to exist. We also would like to kind of like put some different types of pain and what are the available lines of pain management that we have for porphyria patients. I must say that there are porphyria treatments that work also on long term for pain, and they have data to support them when it comes to the pain parameters in general. So we'll talk first about the pain classification and mechanism in general. We will talk about the clinical presentation of acute hepatic porphyrias between and during the attacks. We'll talk about how to test for a particular type of pain that I'm particularly interested in studying called the neuropathic pain and the management of pain in between and during the attacks. So pain is the number one reason why people would go to seek medical care. It's a protective mechanism in the sense is that if you hit something and you don't feel the pain, you're probably going to hit it again. So pain is created primarily to protect your body against injurious stimuli. The important aspect of this topic in particular that pain should be considered as an experience and should be put in the context of how you're feeling at the moment. Let's assume for the sake of argument that you are an Ohio State fan. Basically 2 weeks ago you were playing Michigan in the big house and you have a big win, and then your son comes toward the end of the day and steps on your toe. Perhaps you're not going to be that annoyed or in pain or yelling at him as much as what would happen 1 week later when you lose the Big Ten final against Indiana University and your spouse steps on your toe. So I would think that the second occasion will be much more painful to you because you are already in a mode that sets you up into perceiving more pain. So we have to think about pain as an experience, and pain in general does not like tell us about the severity of the nerve injury as much as other sensations like tingling and numbness or weakness as a function tell us. So again, pain should be severity should be taken in the context of how you're feeling at that point or that day or that week overall. So the three different types of pain in general are nociceptive, neuropathic, and nociplastic. And nociceptive can be divided into either musculoskeletal pain or visceral pain. Musculoskeletal, like any knee arthritis pain, it is dull aching. You can point to it. It is well localized. It is worse typically with movement, while the visceral pain is deep. You cannot localize it that much. It comes in waves like GI cramps. The nociceptive pain is elicited by painful stimulation of normal tissue or a tissue that is already diseased. This needs to be very, very well definitively differentiated from what we call in our books neuropathic pain, which emerges from an abnormality in the nerves or the nervous system in general. Okay. In neuropathic pain, the criteria of it is different. There should be more of tingling, numbness, or electricity-like pain. It's typically burning, and there are sensory phenomena associated with it with three fancy names like hyperesthesia, like when I touch the skin, the touch feeling is feeling much more than what is typically expected, or hyperalgesia when I introduce like a minor pinprick that jumps out of pain, or the fancy term also called allodynia when I just touch the patient and the patient feels in pain. So this is a pain sensation for non-painful stimuli as called allodynia. All of these indicate to us in the community of neurologists that you are having a problem with the nervous system, not just pain in your joint or in your back, etc. There is also one last type of pain, as can be seen in fibromyalgia, called nociplastic, and that's after a period of time of having pain, the pain centers in our brain gets reorganized again in order to give us continuous pain even without any painful stimulation. I would like to focus today about on neuropathic pain because basically this is something that we objectively see all the time in porphyria patients. So we talked about the pain category when it comes to causes of pain. Now we talk about what is the difference between acute pain and chronic pain. Typically, acute pain lasts for less than 1 month, while chronic pain continues to linger for more than 1 month. And there are three different mechanisms, as I will come to later, that would turn the acute pain into a chronic pain that the patient would sadly continue to suffer with for longer than 1 month. So this is, I don't know if you guys could see my cursor, but this is the pathway of pain. The pain starts at the pain receptors, which are typically very fine nerve endings. We call them the small nerve fibers. And that goes into the peripheral nerves, the larger nerves, and then it goes to the spinal cord, and then it goes to the thalamus, which is the gateway of all our sensations in the deep brain. And then it goes to the superficial part of the brain, which is the cerebral cortex. At every stage, okay, pain is first transducted, which means that, or transduced, which means that a pain sensation is transformed by those into an electrical impulse, and that electrical impulse travels along the nerves up to the spinal cord, and then from the spinal cord to the thalamus, the deep part of the brain, and then to the superficial cortex of the brain where you can perceive it as pain. At all of these stages, there are mechanisms that would happen to maintain the pain for a long time, sadly, in some of our patients, not just during the attacks, but also in between the attacks. And the sense is that those free nerve endings has on them sodium receptors or sodium channels that whenever we get exposed to a painful stimulus, they fire. And we know in acute hepatic porphyrias that the liver sometimes secretes pro-inflammatory or inflammatory chemicals that would increase the presence of those sodium channels on the surface of the nerves in order to make the nerves more susceptible or more sensitive to pain. Also, we call this process peripheral sensitization here, meaning increasing the amount of sodium channels on the free nerve endings, which makes them more hypersensitive to pain. And that was found to be due to evidence of increased inflammatory mediators secreted by the liver, unfortunately, to make the nerves more sensitive to pain. There is all this mechanism while happens, not only happens on the peripheral nerves, it also happens at the level of the spinal cord, where a certain receptor called NMDA receptor gets overpopulated or gets more presented at the back aspect of the spinal cord to make the pain more continuous. We don't know a lot about this one as much as we know about the peripheral sensitization. So this is peripheral sensitization and central sensitization. And then on the upper function or the higher function of our brain perception to pain, the pain centers or the areas that are responsible for feeling the pain or perceiving it, they start to kind of like reorganize and become more important and slightly larger in surface area, so that patients would sadly feel more pain for more time. So it is not just relying on if the painful stimulus is mild or severe. Our body has mechanisms into it to amplify or play down the pain. In acute hepatic porphyrias, it has been reported that anywhere 95 to 100% of patients during an attack would have some sort of pain, mainly the acute abdominal pain. But also, we found that up to 2/3 of patients in between the attacks would have some sort of pain too. This is the Explorer study, that's a prospective study that monitored what symptoms would patients have during the attacks and in between the attacks. And I wanted you to look over in the upper trace here to see that basically a large number of patients during the attack, almost 100% would have acute abdominal pain, followed by arm pain, followed by back pain, and all of that. It also should be noticed that the pain belongs to the severe category. So when all of our patients get asked, how would you rate your pain on a scale over 10? If 10 is the worst pain ever, they would say 100. It is more than 10. But for the sake of that study, they tried to be more objective, and they found it to be anywhere between 8 to 10, mostly 10. In between, actually before that, still during the attack, this is a figure that we published in our study about pain in porphyria. We found out that the first pain, typically in most patients, that starts as the acute abdominal pain, followed by which starts right with the onset of the attack, followed by the back pain, and then after that, the limb pain, mainly the mainly the upper limbs in most people, and sometimes the lower limbs too. And then the weakness, if the attack is untreated, goes on. And perhaps before the end of the attack, the weakness is not going to recover, while the pain may start to improve before the end of the attack. So, in order, abdominal pain happens first, low back pain after that in most cases, and then limb pain after that. So, why does acute abdominal pain happen during the attack? It is widely considered that acute abdominal pain is a sign of autonomic dysfunction. And the fact that those small nerve fibers we talked about, they exist also in the GI as nerve receptors or pain receptors. Another mechanism could be that there is local spasms in the abdominal blood vessels has been also suggested, but most of the time we consider acute abdominal pain as a sign of an autonomic nerve damage in the GI. And this was found in lab models where we saw that the actual destruction of the small nerve endings in the GI of the mice model of acute hepatic porphyria. In between the attacks, I mentioned earlier, anywhere between 50 to 65% of patients, depending on what study are you quoting, they continue to have also acute abdominal pain and low back pain and limb pain. So, but this time around, most of the patients in the Explorer study, they mentioned that the pain is not as severe, of course, as during the attack, but it continues to linger around the moderate range of pain. So why do our patients continue to have pain in between the attack? It could be that the ALA, which is the major metabolite of the heme that gets increased during the attack, it could be still hurting your nerves in between the attacks and could be still elevated, okay? Perhaps the patient did not recover yet from the attack and the nerves need time to recover. There are all sorts of mechanisms that we talked about earlier, the peripheral sensitization, the central sensitization, and the reorganization of pain centers. And also expect that if you've been on narcotics for a long time, there is something called medication overuse or rebound pain, that whenever you decrease the dose of narcotics or stop them completely, you're going to get into rebound pain for a certain period of time. So these are the 4 proposed mechanisms for pain in between the attacks. So why do we have to have investigations for pain? As I mentioned earlier during the presentation, that the severity of pain does not correlate that much with the actual nerve damage, because again, pain is an experience. It's taken into the entire context of how you feel in that day or how you feel in that week or that month. We have different investigations that we try objectively to use to assess the severity of the nerve damage, okay, but that does not correlate that much with the severity of pain. We can do nerve conduction studies, but typically these do not help us with the small nerve fibers. But when we think about assessing the small nerve fibers, there is always something called skin biopsy, where we take a sample of the skin, which is 1/8 of an inch, and look at the small nerve fibers under the skin level and try to count them. And we have normative values for men and women for every age decade. And if they are damaged or reduced in number, that's a sign of small nerve fiber damage. We could also, in the autonomic testing lab, assess the sweat abnormality, because sweat is another function of those small nerve fibers in addition to pain. Also, we can assess how severe is the painful stimuli is perceived by the patient using something called quantitative sensory testing, but this is not approved by insurance, and most of the academic medical centers in the US at least do not have that technique. Still remains to be that medical history, actually sitting with the patients and listening to them and examining them, is the best way of assessing neuropathic pain before all of this kind of testing. So it is very, very important to diagnose neuropathic pain and differentiate it from nociceptive pain, because your regular analgesics, over-the-counter analgesics like NSAIDs and Tylenol, all of the, and actually most narcotics too, will not help with the neuropathic pain that much. Neuropathic pain needs different kind of treatment. So moving over to the important part of this presentation, the pain management and acute hepatic porphyrias. During the attack, we are always trying to manage pain with opioids. And when patients are hospitalized, they are in excruciating abdominal pain and all of that. We typically resort to Dilaudid.
I'm sorry, what?
Sorry? Do you guys hear me?
Go ahead. I think that it was a mistake. Go ahead.
Okay. So we typically rely on strong opioids like morphine, um, mipridine, all of that. And typically, most of the patients that I have seen actually needed a Dilaudid PCT, like a pump. And some of them also, while in the hospital, needed benzos, like Valium, to potentiate the analgesic effect of pain and reduce the anxiety. We could also do, in addition to that, two things, like earlier initiation of neuropathic pain medications like gabapentin and Lyrica, which actually act very fast if you increase the dose fast during the hospitalization. And early physical therapy is very important, or early physical therapy consultation while still in the ICU or on the ward would still very important for early rehabilitation from such painful condition. But the core treatment during the acute attack in the hospital will still be using narcotics. While in the hospital, if you are in an acute attack, we will also start using IV heme infusion like panhematin here in the US. And basically, it was found that the effect of panhematin, once the diagnosis is established, typically what happens is that the urine BBG, which is a marker for the acute attack, starts to go down after 2 to 3 days. The pain and the nausea start to improve within 4 days, but the weakness does not start to improve. However, it should remain stable after 3 to 4 days treatment with panhematin. So it was also found that IV heme infusion helps with your pain during the attack. But how about in between the attack? And that's a more important issue for most of our patients. Our current research indicates that there is a degree of small nerve fiber damage in between the attacks that continue to linger in our patients, causing neuropathic pain on daily basis. The first thing that we should do about that is to always try to think about how do we prevent further attacks from happening, because with every attack that happens, life becomes more painful. So we try to stay away from medications that would provoke an attack, alcohol and smoking cessation, stress coping, and all of that. If a patient is having more than 2 attacks within 6 months, hormonal treatment like LHRH analogs in coordination with the OBGYN doctors can be very helpful in that, to prevent the menstrual cycle from happening and to prevent the attacks from further accumulating on the patient. It was found that the new medication, givosiran or Givulari, could lead to reduction in the pain scores from day to day between the attacks on the long term. So it has a protective effect on our nerves. Some patients also use heme on demand or recurrent heme infusions every week, every 2 weeks, every month. And a British study found out that this recurrent or weekly or monthly heme infusions lead to decreasing the frequency of pain by 67%. Sadly, some of our patients, I know some of them that are not responsive to IV penhematin or givosiran or anything. And in those patients, we typically start to evaluate them for liver transplantation, which is actually curative in acute hepatic porphyria, leading to reduction in the attack recurrence and improvement in the chronic pain. On the non-pharmacologic part, in general, we would like our patients to do something in addition to medications, including physical therapy, tai chi, yoga stuff like this, meditation. This could manage to reduce the frequency of pain and the severity of pain, but make no mistake, this never stopped an acute attack from happening. And also the benefit of them is temporary as long as you practice them. These are the pharmacologic treatments for chronic pain and acute porphyria. I wanted to focus on antidepressants and anticonvulsants, medications that were invented primarily for depression and seizures, while the main use of them now is treating pain. Typically, I wanted to focus on duloxetine or Cymbalta or amitriptyline. These are medications that are good for neuropathic pain, can be taken daily. It should be noticed that if you start on a medication like duloxetine or amitriptyline, expect some benefit from that in 3 to 4 weeks after you start them. These are not PRN medications. You cannot take them as needed. They need continuous use. And fortunately, they don't have an addictive potential at all. But again, they need to be used for a long time. Gabapentin and Lyrica are anticonvulsants, and you can use those PRN. You don't have many patients take them on a regular basis, but we always encourage the patients to have like an extra capsule of Lyrica or extra tablet of gabapentin to use whenever the pain is too much, but there needs to be an established level of pain control with a basic dose of gabapentin or Lyrica. Again, these are not addictive, and we should not worry about the risk of addiction or rebound pain after we stop it. If you stop this medication, the pain may recur back, but it's not going to be more severe than it used to be. Other options for that are the benzodiazepines, the opiates, and the cannabinoids. These are having issues with addiction and all of that. They are, especially the cannabinoids, are promising. And the recent International Porphyria Symposium, Dr. Naik, she presented her data, which were convincing data about the use of these agents, and most states now have legalized the use of them. So, and the most important thing, they are not potentially porphyrogenic, in the sense is that they are not going to drive you into an attack. This is an important slide for how do we use narcotics in chronic pain. I would say that we typically, for the chronic, always recommended that we start with Lyrica, gabapentin, Cymbalta, all of these options. And then if we need narcotics, we can use them. We don't discourage using them, but they should be some sort of second line after using the medications that are typically targeting the neuropathic pain. It should be also noted that while in the acute stage, we can give benzos with narcotics in the hospital. Typically, most pain treating physicians or neurologists or hepatologists or pain or specialists in general would not let you be on narcotics and benzos combined for a long time. And that's an issue with different state medical boards because they fear that that would increase the risk of respiratory depression. In Dr. Knight's study in 2016, she found that half of her patients disliked being on chronic narcotic treatment, and actually 19% of them fear that they are going into opioid addiction. These are the medications from the narcotic standpoint that we use. Typically, we use tramadol or oxycodone, hydrocodone are moderately effective in neuropathic pain. These are the three agents that I use if the Lyrica, gabapentin, and the Cymbalta are not enough, okay? And basically, if the neuropathic pain gets above 7/10, we recommend that we give the patient what we call heme on demand, which is a standing order for heme that the patient goes to at an infusion center that they know and get a heme dose to help with that pain. I would recommend that any patient who receives more than 50 milligrams of morphine equivalent, which is more than 50 milligrams of hydrocodone, for instance, needs to keep an Narcan in their home for fear of opioid toxicity and all the side effects. With your pain specialist, they should always assess the risk of two things. Number one, development of respiratory depression, especially for some reason if you are on benzos and narcotics at the same time, which is strongly discouraged now by the government itself. And number two, the risk of taking the medication in non-prescribed manner or abuse. And we always note in our notes, like, what is the morphine milligram equivalent? Because as I said, if you are taking more than 50 morphine milligram equivalent, there needs to be an Narcan in your home. And we are typically assessing the efficacy of analgesia. What adverse effects are you having? Are you using them outside is the patient using them outside the context of pain? How are they affecting or improving your quality of life? And how is your mood on them? And are you sleeping? So that's what we typically do in a visit. This slide is very important. Not every anticonvulsant or muscle relaxant or antidepressant is safe in porphyria, as you all know by now. The traditional old seizure medications that are still used for pain, by the way, including valproic acid and Tegretol and Topamax, are not safe in porphyria and potentially porphyrogenic. Also, some of the muscle relaxants like Soma and Flexeril are also probably unsafe in porphyrias. So this is the last slide in the presentation. We would like to establish some take-home points that chronic pain is still prevalent between the attacks of acute porphyria because there is still some damage to the small nerve fibers. We call the small fiber neuropathy that continues to linger between the attacks. It is very important for the clinician to know whether this pain that the patient is having in between the attacks is neuropathic pain or nociceptive pain. Pain in acute porphyrias can be due to impairment of the small nerve fibers as I mentioned, neuropathic pain. Narcotics have a role during the acute attacks, but should be second line to certain anticonvulsants and antidepressants in between the attacks. And please ask your physician to prescribe you Narcan or naloxone high dose if your narcotic morphine milliequivalent is more than 50 per day. And with that, I would like to thank the United Porphyria Association again and all my colleagues and the Porphyria Consortium. Special thanks to Kristen Whedon and Dr. Desnik and Dr. Petchik for their help with this publication that came about 2 years ago. And thank you so much.
Thank you very much, Dr. Kazamel. I can't help but to get, a bit emotional over all the information that you have shared with us because I bet the majority of us that are single, that are sitting here today for the first time have some answers. The depth of detail that you've shared with us makes us feel understood, makes us feel like every pain that we experience, someone else on the other end actually gets it. And they're not just saying, no, it's just in your head. So thank you for that. Thank you for that explanation. And I noticed that some caregivers are here today. It's a testament to you wanting to learn more about this awful disease for your loved one to understand what we go through as patients. So sorry about that. But truly, it got me really emotional to feel the support, your specific support, Dr. Kazamel, your interest in understanding porphyria and chronic pain and doing such a beautiful job explaining that for us. So thank you so much. I really do appreciate that. And as you can read from the chat, people feel the same way. We have quite a number of questions for you, so we're going to go ahead and dive right into those questions. The first one says, I would like to know a bit more about what low-grade daily symptoms means because several people mentioned this term on forums, but I really don't understand what it means.
So many patients in between attacks develop chronic um, daily pain, mainly acute abdominal, I'm sorry, not acute abdominal, abdominal pain, low back pain, pain in the arms, proximal here mainly. Pain in the neck too is quite prevalent. I would say that we have to be very vigilant for this all the time, and our qualitative research indicated that some of these daily mild symptoms, we need to pay attention for them because some of them may indicate that there is a risk that the patient is going into an attack. I would raise special attention toward insomnia for several days because many of our patients told us that behavioral disturbances and insomnia is quite important right before the attack starts. So it is important not only to pay attention to the mild symptoms that patients encounter between the attacks, but also is the trajectory of these symptoms is changing or not? Are you developing like behavioral changes? Are people getting less sleep? And I would say that single most important thing that you could do as a patient for yourself, if you start developing the insomnia and you think that this is driving you over into an attack, is stay away. Let your primary care and hepatologist and neurologist know this first thing to do, and also get away from stress. This is as much as possible because we found out that the number one inducing provocative stimulus for a patient to get thrown into an attack is not just the medications or the alcohol or the smoking. It is stress, whether at home or at the work environment. So I would pay attention to sleep if I would choose a symptom that sound to be trivial for the majority of clinicians. I would always pay attention in between the attacks to sleep.
It's very true. As an AIP patient, I can tell you it's definitely a prodrome for me as well. So beautifully said. Thank you for explaining that.
Thank you.
This one, Dr. Cozumel, is a question that has to do with a spinal cord stimulator. Just to give you some context, this particular patient has been dealing with terrible chronic pain for the last 12 years. There has been multiple doctors, including experts in the field, who um, she's gone to, but they have never necessarily used the spinal cord stimulator as a solution for chronic pain in AIP. So this question is for you relevant to AIP specifically. Are you
Yeah.
aware if a spinal cord stimulator would work for chronic AIP?
I would put my opinion based on small fiber neuropathy in general, not just in porphyria, because we don't have data about AIP um, with spinal cord stimulators. I would tell you also about my experience with the patients that I received or I referred for spinal cord stimulators. Two very important topics here. Number one, they will work, okay? In my experience, they will work for maybe a year or two, but it is not a permanent solution.
I see.
So if you think that a year or two of, mainly a year, I would say, of pain relief is worth it, I would say go for it. Okay. It will work for this period of time with frequent follow-up with the pain management specialist that will adjust the spinal cord stimulator. That will work for some time. But you should bear in mind that some of these spinal cord stimulators are not MRI compatible. And many times, if, for instance, we need an MRI on you, it is going to be a little bit difficult in the sense that some of them need to be removed before the MRI happens. And most of them are still MRI incompatible. So this is a very important point to take into considerations because many of our patients would eventually need an MRI on the neck, on the C-spine or the lumbar spine.
Right.
So these are the two important um, concerns that I would raise: the lack of MRI compatibility, and also that this is not a long-term solution.
I see. And this is the follow-up to this particular question. It's in the chat right now. What about a splanchnic nerve block? I think I'm saying that correctly.
Yes, splanchnic nerve block would work for the abdominal pain in many patients also. Okay, but once again, this is a transient solution. I am not quite sure how long does it work, but it works for less than the spinal cord stimulator. I would estimate it to be helpful for like 3 to 6 months.
Got it.
But it is quite helpful only for the acute for the chronic abdominal pain, while the spinal cord stimulator is helpful for the lower limb pain more than anything else.
Okay. Okay. This is a specific question more if the person came to see you, could you tell me in an appointment directly with you how much of my pain is likely permanent nerve damage versus potentially reversible factors?
That's gonna be a little bit difficult to promise a definite answer to that question because every patient is different. But we assess everything and we try to be as specific as we can specifically with AHP patients, because I know that everyone is looking for answers. But we do our due diligence in letting you know what to expect and be honest with you about whether you transitioned into a chronic stage pain already, and then it becomes like a pain management issue. But I tend to be very, very focused on prevention of further attacks because this is very important to the patient and to me, because with more attacks, you are liable to more nerve damage and you are liable to more pain over the
Right.
years. The other thing is that we try to manage the symptoms as they exist, and basically we try to kind of like improve the activities of daily living for the patient. But whether we could, as clinicians, predict the future about how long this pain could continue, or what will eventually happen, I doubt that we are able to answer a question with that um, specificity, given the presence of too many confounding factors.
Hmm. Okay. In your presentation, you mentioned potential liver transplantation as
Yes,
a possible solution. And this question says, will liver transplantation reduce my chronic neuropathic pain?
we found, yes, that was reported that it would reduce the severity and the frequency of I'm not quite sure about the chronic pain, but eventually my opinion that it will. And the reason for that is that if you are having less attacks, okay, if you are no longer having attacks of porphyria because there is a new liver in your body, then what's going to happen is that the pain will stabilize and not get worse in most of cases. Will a hepatologist refer you for, if you are no longer having attacks and you having chronic pain, will a hepatologist refer you to liver transplantation for chronic pain? I don't think that this is what is recommended, to be honest, because this is just a very intensive surgery. And don't forget also about the side effects of the medications that you are going to receive to prevent your body from rejecting the new liver. And some of them actually could cause mild degree of nerve damage, like Prograf or something like that, and all of these medications. So if the question was directly related to pain improvement, yes, but it's going to be through reduction of further attacks.
I see. You know what? I was reading that in some cases, our brain is trained to essentially have that phantom pain even after the fact, just because it's learned. It's something that's lived with the patient for a really long time. I would imagine that in AIP, it's something very similar, whether we're talking about a leg being amputated and being phantom pain, it's almost the same with a liver transplantation as well, for us with AIP.
I would say that this is a point that I alluded to when I was talking about the reorganization of pain centers in the brain. So this is one of the mechanisms of the coronization of pain when the pain moves to after years of having pain into a chronic process rather than just episodes and relapses of acute pain that comes and go.
Mhm. Absolutely. We have about five more questions that we're going to try to fire through because we have 5 minutes left. So let's get through them as fast as we can. Are there strategies to manage fatigue and autonomic symptoms that often accompany nerve injury?
Can you repeat the question, please?
Are there strategies to manage fatigue and autonomic symptoms that often accompany nerve injury?
That's a great question. So fatigue in between the attacks. Our research found out that the vagus nerve, which is responsible for slowing down our heartbeats when we are not doing any effort, is technically impaired in between the attacks. And what that leads to is what we call resting tachycardia. Imagine that you are sitting and your heart rate is continuously 110. Obviously, that would lead to fatigue. Okay. So this is one of the mechanisms of small fiber slash autonomic neuropathy involvement on the chronic in the chronic patient in between the attacks. That fatigue is one of those mechanisms due to a vagus nerve problem that is damaged by the ALA. So having a lower resting heart rate is very important in any patient who has this kind of fatigue. And I would say seeing a neurologist who have a particular interest in the autonomic nervous system would be helpful. There are medications that could slow down the heart a little bit and help with the fatigue on the long run. And there are also types of activity and physical exercises that would improve the vagus nerve tone and slow down the heart. But also, patients could be fatigued due to pain chronically in between the attacks. But I would specifically emphasize on the importance of looking at your heart rate while resting, specifically the heart rate when you wake up. We call it the baseline resting heart rate, and see if that's getting up, 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 up. That would be something that we are able to treat and help the fatigue with.
Got it.
That's a great question.
Wonderful. Thanks for that response. This patient has HCP and has had many, many attacks over their lifetime. They're currently being worked up for an autoimmune because of consistent pain they're having in their hands and in their feet since July. This doesn't feel like a regular porphyria pain to the individual, but more like a constant, never-ending pain. Um, it's so bad to the point where it doesn't feel like it's what they have experienced in the past as far as other types of porphyria pain. Could this be related to some other type of pain that's not necessarily porphyria?
Yes, but that will be um, a lot of unfortunately bad luck, because typically the coexistence of HCP or any acute hepatic porphyria with autoimmune small fiber neuropathy could still happen. I would urge the patient um, to seek help from her neurologist in trying to test all the paraneoplastic antibodies and the autoimmune panels to make sure that there is an actual antibody that is known to cause an autoimmune neuropathy. Um, the question that is behind this that I'm sensing is that could an autoimmune treatment like IVIG help a patient with porphyria? I would not use IVIG unless there is a specific antibody that I would see. And we are typically like we know that patients are suffering anyway, and I would myself with any antibody that has any relationship with an autoimmune neuropathy use IVIG for 6 months and see what the patient uh, how the patient feels about it. The problem is that sometimes insurance, this is a very expensive medication, and sometimes insurances don't approve it, but we fight them teeth and nail till we get the medication approved.
Yeah, great. We're so grateful for doctors like yourself who help fight for us for sure. How are you on time, Dr. Kazamel? We're exactly in the top of the hour right now. I don't want to keep on asking more questions. If you need to go to the next lecture, or can we borrow you for another 5 minutes?
5 minutes would be fine. Thank you.
Okay. All right. Here we go. You said that cannabinoids are promising. Is there any specific type that you recommend? Any dosing? Anything specific that you could share that we could take away?
Uh, Unfortunately, I have not used them. Okay, because I use them, so I would defer to a pain specialist for that. I expected that question. I'm sorry, I'm not ready for it.
Okay, not a problem. Is there any contraindication for receiving panhematin frequently? Can it harm our organs?
It could give iron overload, and typically it is mixed with albumin, and to that's to reduce the injury to the large veins that we give it at. So yes, it could lead to iron overload, and it could lead to inflammation in the veins if not. So to reduce that, it should be always mixed with albumin rather than water, of course, and given within a large vein like the central vein. Of course, it is not that easy to do that, but this is the best way to reduce the vein injury. And I am not quite sure if a certain amount of panhematin could lead to iron overload and diabetes and all of that. But I've seen patients who have been on panhematin monthly or twice a month for years and not they didn't develop the iron overload that much.
I see. Perfect. I want us to go back to the question regarding the hands and the feet, the individual that has HCP that has that's going through this pain. The question specifically is how does a provider determine when symptoms are porphyria related versus related to some other type of perhaps autoimmune?
That's another great question. So basically, there is, as I mentioned in my slides, we have tools to objectively localize where is the nerve damage is. Is it in the arms? Is it in the legs? Is it all over? Is it one side? All of that. We have the nerve conduction studies. We have the autonomic testing. We have the skin biopsy. And all of those, in addition to, of course, listening to the patient, there is a particular pattern of neuropathy that happens in porphyria during the attack and in between the attacks. And it really relies on the experience of the neurologist and if they've seen porphyria cases before into determining if this is porphyric neuropathy or a neuropathy to another cause. Whenever I see a patient with porphyria, even if the patient has porphyria, I also test for other things. I test for A1C, I test for vitamin B12 deficiency, I test for ANA, rheumatologic markers, autoimmune, paraneoplastic, all of that. So we test for other things too. And if the picture is mixed and we are able to establish that there is another etiology for the pain, we treat that. But if there is no antibodies, the classic nerve damage in the upper limbs more than the lower limbs, the small fiber neuropathy is there, and there is no antibody, there is no other reason why the patient would have porphyria. We continue to manage it as a case of only porphyria. One other thing is that typically pains due to an autoimmune disorder, they have an autoimmune neuropathy, they have like a different prodrome than the porphyria attack prodrome in the sense that typically these patients have weight loss with the beginning, night fever, shakes, and then they start having one arm weak followed by the other, then the nerve pain moves to one leg followed by the other. It's a step ladder course rather than the gradual ascension that happens in porphyric attacks. So really the best test of that is the wisdom of the neurologist seeing the patient and determining what level of evidence if the patient has another etiology of the neuropathic pain other than the hepatic porphyria.
Absolutely. Perfect. And then last one, does alpha lipoic acid help
Yes.
repair neuropathic damage?
Okay. So the scientific evidence of alpha lipoic acid that was done here at Mayo Clinic years ago saying it is not that worth it. However, I have heard multiple patients here and abroad who are specifically more on the diabetic small fiber neuropathy group, not porphyria, benefiting from it and for a long time. So I would say every study has its limitation. Probably the research that was done on it has limitations, but it is a useful medication according to the word of mouth of many of my patients.
Okay,
I hope
perfect.
that this is helpful.
No, it definitely helps for sure. Well, we have come to the end, the conclusion of our time together. I can't thank you enough, Dr. Kazamel, for really taking the time to really give us all the knowledge, all the information that you have shared with us. And aside from that, staying with us a little bit longer so that we were able
No worries.
to ask those additional questions. Before I let the rest of the group know, I would like to encourage you to follow us on our social medias if you have not followed us yet. There's always a ton of information, lots of stories that we like to share within our community. We want you to feel part of what we are doing within our community. You are part of it. Just the simple fact that you have porphyria automatically makes you part of our poor family. Aside from that, we have an ambassador group that allows us to be able to connect with one another so that there is never ever a person that has porphyria out there that feels alone. This is a one-on-one peer group discussion that allows us to be able to connect with another individual. We also do connect up groups that allow us to be able to connect in a group setting. And we, of course, have also Porphyria Together group on Facebook that allows us to ask immediate questions. Oftentimes, we will have doctors that will come on there and answer some questions, or if not just of the community itself. But it's awesome to be able to have those resources. And then ultimately, if you are dealing with any other diagnostic issues, whether if you haven't been diagnosed or have been diagnosed but are dealing with other things similar to what we discussed today, we have an incredible patient navigator, Erin, who is able to help you navigate the medical system and be able to give you the resources that are necessary to ensure that you get the answers that you need. So, thank you so much. Again, I really appreciate everyone's time. I appreciate your energy of spending the last hour with us and learning alongside with us. So, Dr. Cozumel, thank you so much once again. Have a
Thank you.
beautiful
Thank you for
remainder of
having
this
me.
Wednesday, everyone.